Ken, thank you very much indeed, and particularly thank you very much indeed for the opportunity to come and speak here this afternoon. I think it's a really crucially important session, this, because at the end of the day, the kind of level of policies I think we're going to need to invoke to produce change have to be made at the level of political decision, government policy decision, and not, as we just heard, by leaving the profession alone to resolve the situation, because there are just too many vested interests. So this is what I'm going to talk about today. I'm going to give a quick overview of the global burden of oral disease, to ask why disease remains such a major problem when we can prevent it readily. How do we need to think differently, therefore, to address the problem? What can we learn from others? And then what practical steps within Europe can we begin to take? In general, the mouth matters to all of us. It's fundamental to overall health and well-being. An impairment of oral function has impacts on our ability to interact with others, to attend school, to function properly at work. And there's a very big social burden that follows that. It has big psychological impacts. It has impacts on social well-being. And crucially, it has an adverse impact on economic productivity and national development. It's a major problem on a global scale. As we've already heard, there are major inequalities both between countries and within countries in terms of severity. It's a major public health issue for high-income countries. It's a severe and growing problem in low to middle-income countries. And as I've already said, major inequalities exist both within and between countries in terms of severity and prevalence. And I think this is one of the most important observations to make, really, that there is a gradient of risk across the whole population, so that the lower a person's social position, the worse their risks and the worse their health is. And the poor and disadvantaged have higher risks of disease and worse health. And that applies to oral disease as well as it does to the other major diseases of the 21st century. The burden that we face is principally from caries, from periodontal disease, oral cancer, oral infections, and developmental abnormalities, and I'm not going to spend a long time talking about those, but there are a couple of key points to make about the burden of dental caries that are, I think, perhaps worth emphasizing. This is what the US Surgeon General said in 2001. What amounts to a silent epidemic of dental oral diseases is affecting some population groups. And this burden of disease restricts activities and so on. You can read the rest yourselves. In the United States, 51 million school hours per year are lost because of dental-related illness. And the problem is exacerbated. Again, the social gradient begins to kick in here because children from low-income schools are 12 times more likely to miss days at school because of dental problems. So if one's looking at a fair and equal society, you can see that the inequality is absolutely encapsulated in those three simple statements. So why is it that oral disease is still a major global problem? In large part, it's due to our failure to implement what we know to be effective in terms of prevention. But I think also, and for me, this is my kind of light bulb moment in the last 5 years, it reflects a failure to understand the importance of the social determinants of oral diseases and their action. And I think one of the people who's done more than almost anybody else to bring that to our notice is sitting on my left this afternoon. It depends also on a reliance of activities that dental practitioners can deliver to patients. And I think that this issue of providing oral care at the level of the individual rather than the level of populations is another factor that militates against gaining traction. It also depends on advice to people to adopt healthy behaviours and to avoid unhealthy ones. And all the evidence across all aspects, all health domains, indicates that if you want to modify health, you are less likely to achieve anything worthwhile by dietary advice. Legal measures are about the only ones that really have an effect. And if you want proof of that, then you only have to look at issues around tobacco regulation. So what we would argue, or what I certainly would argue, is that we need a radical reorientation if we're going to achieve sustainable oral health improvements and to reduce oral health inequalities. We need a collective paradigm shift in the way that we think about oral disease. And crucially, we need to think about oral health in the wider context of general health. And I was absolutely delighted by the opening remarks this afternoon, where what is plainly happening now within Europe is that oral health policies and strategies for prevention are being incorporated into health policies in general. So where do we go from here? We need to shift the focus from treatment onto prevention. We need to integrate the approaches to oral health into the way we think about the major communicable diseases. And we need, therefore, to have a radical reflection, a radical reorientation. There are a couple of good examples out there in the wider world that I think we can learn from. The first of these is the Smiling Brazil campaign. The second is the Fit for School campaign that's supported heavily by the German Department for Overseas Development. Very briefly, the Brazilian campaign addresses three straightforward levels of action. Fluoride of public water supplies, reorganization of oral health care so that it's integrated into family strategies, and to expand specialist care to sit above it. If you look at the impact on water fluoridation, the colors here don't map very well, but what essentially it shows is that in areas where the population levels are high, fluoridation is now very effective. Very effective distribution of dental kits across Brazil, so that the increase, all you need to notice there is that there's more dark than there is light in 2010, reflecting the increase. The specialist centres have also been increased in large numbers, again from 2004 at the bottom to 2010 at the top. At the moment, I think we need to be cautious about this. Although you'd expect the strategies to be effective, there's no data, but that is one example we can learn from. And I think the other one that's incredibly valuable is the approach that's been adopted in the Philippines, where the main priorities are diarrheal diseases, dental decay, and underweight. And by an integrated campaign of daily hand washing, daily toothbrushing, and annual deworming, at a cost per child of 50 cents, the impact has been remarkable. So more than 30% reduction in days lost at school, a big increase in the number of children now who are at the correct body mass index for their age, reduction in the prevalence of worm infections, and a big reduction, nearly 40% reduction in caries increase. Within IDR, we've looked at this issue. We've looked systematically. There are a number of recommendations. You can see those on the website. I'm not going to spend time looking at them now, because I want to get to the next slide, which emphasizes key actions that we can take in Europe. They are to identify knowledge gaps and target priority areas. We need to implement what we know to be effective. We need to integrate oral health messages into health promotion strategies. We need to recognize the importance of partnership across disciplines. We have got, as a dental profession, to get out of our silos and to get out of our zones of comfort and to begin to discuss more widely with others. And another key role, I think, is to engage with civil society and to work much more with our communities. So my final slide is that good oral health should be everybody's business. We've got a significant role as health advocates. That involves educating and influencing decision makers at forums such as this. And there's a cartoon here, which I hope you can all see, which relates to addressing health inequities as a whole. And at the top, what you see is the role of politicians to bear down on the problem of health inequality, working in partnership with the community, with civil society. That's the strategy that we believe works for health inequity, and that should include oral health inequity as well. Thank you very much.